Hello, good afternoon. I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure today of moderating our multidisciplinary breast cancer tumor board. And I'm going to ask our faculty to each introduce themselves. We have some very distinguished faculty with us today. So we'll start out with Dr. Joyce O'Shaughnessy.
Joyce O'Shaughnessy, Baylor University Medical Center, Texas Oncology, and U.S. Oncology, and I'm chair of the U.S. Oncology Breast Cancer Research Program.
Hi, Terry Mamines, breast surgical oncologist. I work at Orlando Health Cancer Institute in Orlando, Florida, and also chair the breast committee for NRG oncology.
Hello, I'm Dr. Frank Muccini, radiation oncologist. I work for Genesis Care in Michigan.
Hi, I'm Dr. Maxine Chalkelson. I am the Director of Imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I'm a breast imager and a PET reader.
45-year-old, also a young woman with a history of a T1N1 invasive ductal carcinoma of the left breast. This is ER and PR positive, HER2 negative, diagnosed in 2015 following lumpectomy, chemotherapy with doxorubicin, cyclophosphamide, only 3 cycles, presumably because of intolerance of some sort, and paclitaxel times 8. She then had radiation therapy and endocrine therapy with tamoxifen, which finished in 2020. Now with invasive ductal carcinoma of the left breast. So ER/PR positive, HER2 negative. So patient was told at an outside hospital that she could undergo a lumpectomy. And so we want to focus on what would really be the best optimal surgical therapy for her. And given her previous radiation, is there a role for postoperative radiation? And then also for her adjuvant systemic therapy. So we'll get everybody's viewpoint on this one. Again, she presented with an abnormal breast MRI screening because of her previous breast cancer and high-risk population. She has an excellent performance status. As I mentioned, she has a history of an invasive ductal carcinoma in 2015, at which time she had surgery, chemotherapy, which was an anthracycline taxane-based regimen, radiation, and endocrine therapy. Her gynecologic history includes the fact that she's G1, P1. Her last menstrual period was at age 40. No history of hormonal replacement or hysterectomy, oophorectomy. No significant social history, and she has a sister who was diagnosed with breast cancer in her early 30s. The bilateral breast MRI we'll look at here in a second, as well as the other imaging. But the core biopsy, just to remind you, is invasive ductal carcinoma. It's poorly differentiated, ER and PR positive, HER2 negative. The patient had systemic staging with a bone scan and a whole body CT, which was negative for metastatic disease. She did have a comprehensive panel genetic test, which demonstrated a pathogenic mutation in BRCA1. Dr. Chalkelson, if you might highlight some of the imaging for us.
Sure. So there are 2 sagittal views, and I don't know which sequences they have provided. I have a feeling, it's just hard to say, that this is the T2 weighted sequence. And so you see multiple bright circumscribed masses that are most likely cysts. And then the arrow leading to this other guy here, which is not as smooth as the other ones. And then you see some linear enhancement or linear brightness extending up from it. And then this view, which I'm presuming is the same image, I have to say, when I first looked at this, this looks like that it could just be an enhancing rim on a cyst, an inflamed cyst, but since this clearly ended up being the cancer, triple negative, some more aggressive cancers can present looking like an inflamed cyst. But so this is it, and I think the rest of this stuff is most likely just cystic, fibrocystic change in this lady. But just with the 2 images that I have, it's hard to be certain.
Okay, thank you so much. So just to remind you of her oncologic history, she had the lumpectomy with negative margins in 2015. At that time, she had 3 positive lymph nodes for metastatic disease. She had partial breast and regional nodal irradiation in the adjuvant setting, 40.05 gray over 15 fractions. And her systemic adjuvant therapy included doxorubicin, cyclophosphamide 3 cycles, followed by paclitaxel 8 cycles. Her endocrine therapy consisted of tamoxifen, which was finished in 2020. Presumably, she's now postmenopausal. Her last menstrual period was 5 years ago. And so at this point, we would now consider her to be postmenopausal. So Dr. Mamounis, might you tell us what your thoughts are about if she's a candidate for another lumpectomy, or what would be your optimal surgical approach?
So again, this is a patient who, had lumpectomy about 6 years ago, had radiation. Now she has a second primary cancer or a recurrence, hard to tell. But what really concerns me here, she has a pathogenic mutation in BRCA1, and she's 45, had the cystine breast cancer at 30. Now she has like 2 cancers. So I would not be very enthusiastic about a lumpectomy in this patient. In fact, I'll probably discuss options of mastectomy or even bilateral mastectomy, because she still has a residual risk remaining for either breast, despite the fact that she got tamoxifen that will reduce the risk. Again, if she was really adamant about breast conservation and it's a small lesion as we see on the MRI, I could, do a lumpectomy on her. But again, I would seriously discuss the risk of a subsequent breast cancer happening in the next 40 years, assuming that, she gets cured from this, which is substantially high, particularly in the contralateral breast as well.
Terry, how about nodes? Can you get any more nodes? You had 14, it looked like 3 out of 14 before were positive.
Most of the data on reoperative sentinel lymph node biopsy show that if you had the prior axial dissection, it's almost like a 50-50. 50% of the time when you do lymphatic mapping, you're not going to find a sentinel lymph node. Sometimes, obviously, you're going to look at also the contralateral axilla, so you got to look either with lymphocytography or even with a gamma probe at the time, because not that rarely we find enhancement on the opposite. We find uptake of the isotope in the opposite axilla, and we have done sentinel lymph node biopsy of the opposite axilla in that case. So yeah, I would attempt it, but I would tell her that the chances of having so many nodes removed before, chances are low that she would. And if you had the prior sentinel biopsy, about 80% of the times you will find a new sentinel node again. But after axial dissection, it's probably a little less than 50%.
Frank, would you have done partial breast on this young woman?
No, I think the reason they may have done it was because of her mutation. They were thinking just to provide local therapy, I guess, because certainly with 3 out of 3 positive lymph nodes, even though they were included in B39, it wouldn't be something we would have done in a 40-year-old patient. So I would imagine that discussion about, her mutation factored into the decision to do partial breast. And I'm not really sure how they combine that with regional nodal as well. But, getting to the issues, though, that Terry brought up, I'm really concerned about her mutation and the fact that she's at significant risk of getting additional breast cancers, right? So I would talk to her about that, but obviously she's interested in breast conservation. We could retreat her, and because it's been such a short time interval, if she had a lumpectomy with clear margins, we would use the RTOG 1014 fractionation scheme of 150 twice a day for 3 weeks. The additional difficult problem in this patient is the axilla, though, because I cannot go back and retreat the regional lymphatics with radiation, not even with high tangents. I'd be very concerned, doing additional radiation a second time, such a short time interval in such a young patient. So she's already got a lot of reasons that would really push me not to recommend a second attempt at breast conservation.
Okay. So to be clear, just to talk about the local therapy, if this was a patient that, as this patient does, has a pathogenic BRCA mutation, we really would favor mastectomy and consideration of contralateral prophylactic mastectomy, given her significant risk of a new primary breast cancer in the future. In the absence of a pathogenic BRCA mutation, Dr. Mamounis, I believe you said that you could potentially, if the patient was very motivated to want to consider breast conservation, that is something that you potentially could offer. Am I correct in that?
Yeah.
Okay. Perfect. Okay. And then Dr. O'Shaughnessy, do you want to talk about the optimal adjuvant systemic therapy?
It was a 7 millimeter cancer grade 3, ER positive. I would imagine a Ki-67 would be quite high in it, it sounds like. And so this is a cancer I'm a bit worried about. Thank goodness it's small. We may or may not get any nodal information, for her. So if we have some nodes and they're clear, that's great. If we don't have nodes or they're involved, that's obviously of greater concern. But I would tend to be looking for some chemotherapy for this patient. One of the things that's emerging that's very interesting is the concept of the ER-positive basal-like cancer, because this patient's germline BRCA1, and so there's a trial called the NBREAST trial where patients were given chemotherapy of physician's choice preoperatively, looking at PAF-CR, and then all of the cancers underwent both 70 gene signature, the mammoprint, as well as the blueprint, looking for subtyping, luminal A, luminal B, HER2 enriched or basal. And in that study, 13% of the ER-positive cases were ER-positive basal. And they weren't all real low on the ER. They tended to be PR negative, but could have some PR. They weren't all high grade. So you couldn't really necessarily tell them. And then this was corroborated in the I-SPY 2 trial. In I-SPY 2, in order to qualify, patients, if they're ER positive, have to have a high risk 70 gene signature. And in that group, it was 25%, maybe closer to 30% of these ER positive that were 70 gene signature high were basal on the intrinsic subtyping that's done by Blueprint. So there's a group of these. And in the NBREAST trial, when the patients got the preoperative chemotherapy, if they were triple negative and they were basal triple negative, their PAF-CR rate in this particular study was about 34%. And if they were ER positive basal, it was about the same. Interestingly, the luminal A and luminal B, luminal A was basically 0. Luminal B, we thought, oh, gee, maybe that'd be like 13%. It was low single digits because the ER positives that were really sensitive to chemotherapy were in the ER positive basal group. So I think she may be in that category. I would kind of debate whether I would send a blueprint and see it. I probably would just treat her, and I would treat her with docetaxel and carboplatin, of course, if she were willing, of course. And I generally, for sub-centimeter disease, give 4 cycles of chemotherapy. But I would recommend chemotherapy, in several trials. Several investigators have looked at preoperative either paclitaxel or docetaxel with carboplatin in the triple negative setting. And Priyanka Sharma's small trial, 100 patients, 50 in each arm, looking at AC followed by paclitaxel carbo, so 4 drugs versus 6 cycles of docetaxel, carboplatin, AUC of 6 for 6 cycles. The PAF-CR rate in both was 55%. Not huge data, but that's really emerging when I don't really want to go back to an anthracycline. That's emerging as my go-to regimen for triple negative breast cancer, because in the ABC trials, 6 cycles of docetaxel cyclophosphamide was inferior in triple negative breast cancer patients to the ACT regimen. So I'd rather not use something inferior. I like carboplatin, obviously, in a germline BRCA patient. So I would recommend to her 4 cycles of docetaxel carboplatin. You can scalp cool with that quite successfully. And then, of course, she needs endocrine therapy. She needs a BSO if she's willing to do it. And then I would recommend an aromatase inhibitor to her for 5 years.
So, Dr. O'Shaughnessy, the recommendation for the adjuvant carboplatin is coming from because of the germline BRCA1 mutation. Is that why you're recommending incorporation of the platinum?
Yeah, I think the biology of this is likely that ER positive basal subtype. Okay. And so that's why, there was, we're also getting some information from the study that Lias Puzdai presented at AACR in 2020, again from the I-SPY 2 trial. And it was in patients that they weren't all germline BRCA. They were just 70 gene signature high if they were ER positive or triple negative. And the patients received the standard paclitaxel followed by AC and the control arm of I-SPY 2 versus paclitaxel, olaparib and paclitaxel along with durvalumab, followed by AC. And in the ER positive, HER2 negative group, who were 70 gene signature high 2. So that's taking the ER positive high risk patients from I-SPY and putting the median, going in the middle of those patients, their high risk scores going in the middle. We got high 1 below and we have high 2 above. And high 2 is associated with homologous recombination deficiency. And in that ER positive group, their path-CR rate was phenomenal, almost 70% with olaparib, paclitaxel, and the durvalumab. So increasing lines of evidence that there's a group of our ER positives that have considerable homologous recombination deficiency, and they respond like our triple negative breast cancers that have homologous recombination deficiency. Not all of them do. So it's very interesting. And so I would favor carboplatin for that reason. And so the biology of the disease, I think it's likely basal. I think it's likely, 70 gene signature high 2. I could go improve that, but she's got to get treated with something in my mind. So I would favor the carboplatin over the cyclophosphamide.
Perfect. All right. Thank you so much.
Patient, if I can comment, this patient, obviously, she had prior breast cancer, so she probably wouldn't have been in the Olympia trial, but the Olympia trial presently with olaparib. So she may, it doesn't quite fit that profile, but certainly if that's approved in the near future, we haven't seen the data yet, but that's another option for the BRCA.
That's right. And Terry, because she's not out of the woods from her first, that's a very important point, right? She's still got 3 positive node breast cancer. Truthfully, that's really going to determine her outcome. So that's an excellent point.